Dr. Lise Alschuler will return to Australia to deliver her must-see seminar, Managing the Drivers of Cancer. The series will run in Australian capital cities from the 13th to the 24th of November 2017. You can learn more about Lisa's comprehensive prevention and management strategies by attending this vital seminar. For more information, please go to bioceuticals.com.au and click on the Education tab. This is FX Medicine. I'm Andrew Whitfield Cook. Joining me on the line today again is my dear friend Lise Alschuler. She's a naturopathic doctor with board certification in naturopathic oncology who's been practicing since 1994. She maintains a naturopathic oncology practice out of Naturopathic Specialists, a practice in Scottsdale, Arizona. I should say a beautiful place called Scottsdale, Arizona. Lise works as an independent consultant in the area of practitioner and consumer health education. She is current president of the Oncology Association of Naturopathic Physicians, that's OncAmp. She's the executive director of TAP Integrative, a non-profit educational resource for integrative practitioners, which is brilliant and seminal and unique. Lise is the co-author, along with Carolyn Gazella, of The Definitive Guide to Cancer and The Definitive Guide to Thriving After Cancer, texts which any practitioner should read regarding the evidence and safety of natural medicines in cancer care. Dr. Alschuler co-created ithriveplan.com and co-hosts a radio show, 5 to Thrive Live, on the Cancer Support Network about living more healthfully in the face of cancer. Welcome back to FX Medicine, Lise. How are you?
I'm really quite good today, actually. And thanks for having me back. Always a pleasure.
It is always my pleasure, Lise. I'm so happy to speak to you again. Can't wait for you to come out to Australia again later on in this year.
I know. I'm looking forward to that a lot.
Oh, yeah. Now we're going to talk. We're going to talk about the sort of flip side, if you like, today. We're not going to talk about nice, positive things. We're going to talk about dangers. Potential dangers, and look at the reality of these dangers and appropriate use. The whole point is for safe use. So we're going to be talking about the dangers of supplementation in cancer. So Lise, let's start off. What first are the theoretical fears of oncologists with the use of natural supplements during oncological care? And are these fears real?
You know, I think that like humans have a tendency to do, a lot of oncologists put supplements, all of them, into one box.
Yep.
And this box is full of stuff they don't know very much about, and they're afraid that the stuff in there is going to interact with their therapies. So I think the fears are really based on, could any of those supplements potentially make my therapies less effective? That's really their primary concern. Sometimes I hear from oncologists that they're also concerned about potential, increase in side effects from their therapies, but mostly it's really a concern about interfering with their chemotherapy, and certainly radiation oncologists are very concerned about any supplement, almost as if they all are antioxidants, and antioxidants they feel, interrupt the radiation. So I think that's really the kind of the main fear. Now, are those fears justified? I think sometimes they are. There are definitely some supplements that are, I would say, either absolutely or relatively contraindicated with certain chemotherapeutics or certain, types of radiation therapy. But of course, that doesn't hold true for all supplements. So I think really the answer is in a more sophisticated approach to all of this.
Yeah. I remember reading some research by Keith Block, which was basically a review of other research regarding antioxidants during chemotherapy. And it was overwhelmingly positive, not negative at all. But I think the interesting thing is, why do oncologists feel that a supplement can interfere with radiation when there is no basis for giving these things after, say, a leak from Fukushima or Chernobyl? there is no interference with that, with a bad radiation, let's say, an ionizing radiation. So how do they think that an antioxidant would protect against this acute dosing? It's really funny. It's really a sort of a dichotomy of thought about the action of radiation, ionizing radiation.
Yeah, well, I think that it really goes to the fact that radiation is clearly a therapy that's based on introducing oxidative stress.
Yes.
And introducing it in a very concentrated way at the tissue. So therefore, just the word antioxidant is opposed to the intended action of the radiation.
That's right.
So one would then logically assume that a supplement with antioxidant capabilities or the ability to quench free radicals, which are these, charged oxygen particles that radiation is introducing. So one would, I think logically say, well, then if somebody takes something that's going to quench these oxidants, that's going to interfere with the intended effect or the cell damage of radiation. The reality is that kind of surprisingly, actually, that doesn't seem to hold out in clinical trials. There was one big clinical trial that made the rounds in the early 2000s, which looked at vitamin E supplementation during radiation therapy in people with head and neck cancer. And in fact, the first report that went out showed that when these people were followed for 6 years out, there was an increased risk of mortality in the people who had been supplemented with vitamin E, even though during the radiation they had better toleration of the treatment. So this was seen as a big, it made the circuit like nothing I've ever seen and really fueled the fire of, okay, antioxidants are bad during radiation. Now, interestingly, in a subsequent follow-up analysis by the same study authors, they actually found that a subgroup within that group of patients, namely smokers, accounted for 100% of that increased mortality risk.
Yeah.
And they went on to say that there was some kind of specific interaction that was happening between the vitamin E, the smoking, and the radiation. And it might have been more the smoking than the vitamin E, but nonetheless, there was that kind of emerged as the main caution. Of course, that never made the news.
Yeah, no.
And really that study has been used to kind of fuel this ongoing thought process. But, so that's an example. I myself, if somebody smokes, do not recommend that they take vitamin E if they're getting radiation therapy. And in general, I'm just not willing to kind of go to bat for vitamin E during radiation, even in the non-smoker, because I don't think it's going to help enough to kind of raise the ire of the radiation oncologists. But other so-called antioxidants, vitamin C, for example, or CoQ10, even up in doses up to 300 milligrams, have failed to demonstrate any interference effect. And so, maybe it's that the radiation is very short-lived, like it's the way it's introduced. Most of it's gone from the body very quickly, which is why people have to get it every day. And an antioxidant, when we take it orally, it's relatively small amount that gets circulated ultimately throughout the body, and probably not enough in any in a concentration manner to do much of anything at the site of radiation. But I think radiation is an area that I've just found most radiation oncologists are very antioxidant adverse. And I'd rather not triangulate my patients in that. So I just don't really work too hard to give people straight out antioxidants and get a little sneaky with using botanicals that really do have antioxidant capability, but are not considered as such.
Shh, don't tell them. So the conceptual sort of framework that I have an issue with is our term. Antioxidants is polar. It only does one thing, whereas with every antioxidant, there is a redoxidant or a redox pair. So, vitamin C, CoQ10. So you've got ubiquinone, ubiquinol. In between, you've got semiquinone. The same goes for lipoic acid. You've got lipoic acid and the more active, if you like, or intracellular part, dihydrolipoic acid or dihydrolipoate. That rings true for vitamin E, for vitamin C, for lipoic, for CoQ10, for all of these antioxidants that we term as that. Are they really an antioxidant, or are they this redox pair that we're actually helping to stimulate, or indeed stimulate, as I said, the like mitochondrial activity?
Yep, I think that's exactly, I agree with that 100%. And then if we think about it from the perspective of, a lot of, let's say, the botanical so-called antioxidants actually work as oxidants initially. So they introduce, or they're met by the cell membrane as an oxidant, and they induce then a cellular response that's, depending on the various state of the cell, is either NF-kappa B dependent or NRF2 dependent, and that's going to kind of generate the overall cellular response. But in reality, that original compound, which we called an antioxidant, is really working as an oxidant. So I think there's so much more complexity to this from a biochemical perspective that, yeah, I agree. Oversimplifying the issue, I think, is really not helpful.
Yeah. Of course, the other issue is oral dosing versus intravenous dosing. And we know that the vast difference of actions of vitamin C, for instance, given orally versus intravenously, and the doses that you can achieve with such. From a conceptual point of view, what are the real dangers of supplements during medical oncological therapy?
I think that there are some things that need to be considered, and I certainly evaluate this on an ongoing basis. And I think the first thing to consider are cytochrome P450 detoxification enzyme potential interactions. So there are many chemotherapeutics that get metabolized by cytochrome 3A or 2C9 or whatever the case might be. And whether that enzyme is up or down regulated could affect the metabolism of the chemo. Sometimes the chemo is metabolized into inactives, and sometimes it's metabolized into actives. So that's an important piece of information. And so it's important to evaluate for that. Now, we don't really know a lot about the impact of the herbs on those enzymes in the Petri dish when we study this. There are invariably a lot of herbs, most, maybe even all herbs affect these cytochrome enzymes. But in most, I would say even 9 times out of 10, when you actually bring that in vitro data into a human pharmacokinetic study, you fail to see a clinically significant effect of those herbs on the enzymes.
Yeah.
And that makes sense because herbs particularly will get broken down by intestinal bacteria and conjugated. So by the time they get to the liver, they're kind of a different molecule. But that being said, I think there are some examples, like Hypericum perforatum or St. John's wort is a good example of an herb that does have a really strong affinity for the 3A enzyme and should not be used with certain chemotherapeutics like irinotecan. It inhibits the efficacy of irinotecan. That's been clearly documented in humans. There are other, enzymes like, or other herbs like curcumin from turmeric, which has been shown in vitro to have the ability to inhibit 3A or 3A4, 2C9, and those are drugs which you would think would have impacts on chemotherapeutics and other drugs. But in fact, in pharmacokinetic studies with human volunteers, just using straight up curcuminoid powder, there's really no inhibition or no clinically significant effect at doses up to 4 grams of curcuminoids. So I think we have to kind of take all this with a grain of salt too, or at least do our investigation. And last thing I'll say about this is if people are concerned about it, nonetheless, I think the thing to do is to look up the half-life, the terminal half-life of the chemotherapy, and that's readily available online.
Yep.
And let's say we're looking at a taxane, which is about 11-hour half-life. We multiply that by 3 generally to get kind of a good, by that time, most of that taxane is going to have gone through its metabolism.
Yep.
And then just avoid anything that could potentially interfere with it during that period of time. And then you're kind of avoiding potential interactions.
Yeah. Yeah.
So it's kind of a good rule of thumb.
Because I don't know as much as you about half-lives, I basically go 4 half-lives and I go, right, or on the side of caution. But as you say, I think every natural health practitioner needs to really study these half-lives and really be aware of them. And that's indeed something that you include in your book.
And I think that, and I would characterize that approach as a very safe, sort of conservatively solid approach. If there's something that you really want somebody to have within that window of time, then go and see if there's any human data on potential interactions. And sometimes you'll find data that actually negates the interaction. So then you have more flexibility or freedom to use things. And that can be important, like with curcumin, since we were talking about that.
Yep.
There are a slew of studies showing that curcumin is a synergist, or it improves the efficacy of things like carboplatin and cisplatin. So you would want to use that at the same time somebody's getting those drugs. So it's good to know that you're not going to interfere with the chemotherapy. In fact, you're going to enhance its efficacy.
Yeah, that's right. 5-FU as well, right, in colorectal cancer?
Yep, 5-FU. Yep.
I'm so glad you mentioned curcumin, because I remember looking into curcumin with regards to cyclophosphamide. And there was one study I read where it was an in vitro study, and it had an issue with cyclophosphamide with curcumin. But there was a trial done in dogs, I think, which showed a benefit. So where are we at with cyclophosphamide and curcumin? Do you err on the side of caution to say, look, that's dogs and that's great, but we're humans, so at the moment we just don't know, so you're waiting, or how do you navigate that one?
Yeah, you would bring that one up, because so far I'm comfortable with it, with the platins. There's it was a rat study, but seemed to did not affect docetaxel at all. So that's a taxing chemotherapy. So pretty much, comfortable with a lot. Cytoxin or cyclophosphamide is one that the jury's still out on that. I would say there's, this odd overlap of activity in the cell that, because of a pathway called the JNK pathway that curcumin can inhibit, which is normally a good thing and part of its anti-cancer action, that pathway needs to be intact for cyclophosphamide to work at its best. So it's possible that there could be a decrease in efficacy.
Yep.
So because I'm not sure yet, and the data isn't really out there, that's one that, maybe I'd be a little bit more cautious with. Now, having said that, in certain people who have a lot of inflammation and their side effect or the possibility of side effects from chemo is, inflammatory-based side effects is really high to the point that they're afraid to get the chemo or they might not be able to tolerate the chemo, then I think we have to do kind of a evaluation of risk versus benefit. And in those cases, I generally would tend to consider using curcumin, even with a cyclophosphamide regimen.
But do you wait a day or two after the dose?
Yeah, I think that would be
Cytoxin,
best.
Cytoxin's got a quicker half-life, hasn't it?
Yes, I don't remember what it is off the top of my head, but yeah.
Yeah, I thought it was hours, yeah. In those people where you're cautious about a deleterious interaction with Cytoxin, would you say, look, let's fall back to the secondary state, which would be food sources? So do you then say, do you like curries, make it with some curcumin? Do you then use that as a sort of possible way of at least getting some curcumin, some dietary sources in?
I mean, yeah, I suppose that would be one way to address it. I think the other way would be just to avoid the terminal half-life or the half-life times 3 time period.
Yeah.
And then I'm fine using it because, at that point, that Cytoxin has really done its thing for the most part.
So talking about foods, are there foods which can be definitely dangerous?
I mean, I suppose there are some, any food can be a poison in the right dose, right? But, so I'm not quite sure how to answer that. So broadly, I think I would say that, unlike some of the radiation oncologists who don't want their patients eating any vegetables because of the antioxidants in the food, I just don't find there to be very many contraindicated foods. I mean, grapefruit probably is one that I would have to put in there because that definitely has a very strong impact on cytochrome enzymes. So I think you run the risk of altering the metabolism of chemotherapeutics.
Yeah. The funny thing about grapefruit was that if you get an oncologist that just wants to use their oncological regimen as dictated by the guidelines, then grapefruit juice is out. But I thought it was really interesting that there was a couple of stories from a trial, and the trial said, well, hang on, if we can actually use grapefruit juice therapeutically and you measure what's happening with the chemotherapy. So, it takes some action on your part. If that's the case, we can actually have a cost saving. And I think it was something like they only had to give a third of sirolimus. So they can actually have a cost saving benefit from the healthcare dollar, and the patient gets the same action of the chemotherapeutic drug by the grapefruit inhibiting how the drug is metabolized out of the body, and so therefore holds onto it in a greater way.
Yeah, I mean, it makes a lot of sense.
Yeah, I can't see many oncologists doing it, but where I was basically thinking about the food issues was I have this recall of a difference in patients' benefit from chemotherapy if they'd had a meal versus if they hadn't had a meal while they were receiving the dose of chemo. So how real is this? What happens there? What do you recommend for your patients?
Yeah, I mean, this is probably, I'm guessing, related to the sort of newer work, which is currently being studied in a number of clinical trials on fasting for a period of usually at least a day before chemotherapy, the day of chemotherapy, and then sometimes even for a half to a full day after chemotherapy. Right. And really quite low caloric intake, like 600 kilocalories or less, or water fast. And the idea is that with that fasting period, there's obviously a huge drop in nutrients coming in. So normally one of the impacts of that on a cellular basis is cells kind of pause in their cell division. So they stop, doing proliferating and stop kind of their activity declines as they hunker down because they're waiting for the next influx of nutrients.
Yep.
So that would be healthy cells, which means those cells are going to take up less of the chemotherapeutic. So it has sort of a protective effect on healthy tissues. Now, malignant cells, on the other hand, don't have those breaks in place. So they can't hunker down and wait it out. So they keep on dividing. So they remain sensitive to the chemo. So it's meant to kind of expose that differential effect of fasting. And Walter Longo has been doing a lot of work around this and has found some other mechanisms related to insulin growth factor 1 and various, impacts that has on cellular metabolism. But from a clinical perspective, it is a therapy that I try with some people. Not everybody can tolerate fasting. So constitutionally, I think it's only appropriate for some people. But for people who can really manage the fasting, it can reduce their adverse toleration, particularly digestive tract issues. So people who had a lot of nausea and vomiting and diarrhea, sometimes the fasting for just that 2.5 day period really makes a difference. I think in that sense, food can be used therapeutically.
Yeah. So can I ask about this then? So when how people have their dose of chemo, and while they're sitting there, unless they're not tolerating their chemo very well, and so they're feeling really poisoned and really sick, most people, they sort of have this, half day to a day of grace, and then they feel like rubbish for the rest of the week. I guess my concern is if somebody is fasting around the dose of chemo where they could get nutrients where they're feeling okay, and then afterwards they're going to feel rubbish where they're not going to want to eat anyway. You're saying that this work by Walter Longo has actually shown that it benefits them.
Yeah, so that they don't feel as bad later after they feel generally okay that first day because they're full of steroids, and as those wear off, and usually antiemetics that have been delivered intravenously, and as those drugs wear off, their side effects start to emerge. But by managing some of the kind of the damage during the infusion, when those drugs wear off, there's less symptoms to show up, basically.
Gotcha.
At that time. And of course, I think you kind of is getting to or hinting at another issue, which is important, and that's weight management. For some people, they, with any degree of fasting, will lose weight and at an inappropriate time. So that needs to be monitored. In the studies so far on fasting during chemo, weight loss is not really showing up to be an issue for people. They kind of make up the difference calorically between chemotherapy cycles.
Right. Now, going on, I guess, with regards to a food or what's in food, and that's glutamine. And it's recently sort of hit the headlines because some researchers have been tricking cancer cells by using glutamine, and the cancer cells like glutamine. What the message that got out, though, was don't take glutamine in any form, way, shape or form. because it's going to feed the cancer cells. What's the real issue here? Because
Right.
I think there's a double thing here.
Yeah. So I mean, this is actually rather complex biochemistry, but so glutamine is a preferred fuel by many cells throughout the body, like glucose. And we, as humans, whatever beings, make our glutamine factories. So we're making a lot of glutamine all the time. And it's known that malignant cells, some malignant cells can get to a place where the way they make energy is altered for various reasons, and they don't metabolize glucose very effectively. So they need a lot of it because they're not getting as much energy out of it. And they also start to rely on these secondary fuel sources to a greater degree, including glutamine.
Right.
So with that understanding, that's kind of led to this I would characterize a clinical jump to say that, okay, well, if we deprive the body of glutamine from external sources, then we can sort of starve the cancer cells. The reality is that I question whether that has a lot of clinical practicality. Number one, most glutamine that those cancer cells are using is made within our body, so it doesn't really matter if we're restricting it externally or exogenously.
Yep.
Number two, most of the glutamine that we take, even in high doses, like 10, 15 gram doses, most of that is going to be taken up by the enterocytes in the intestines and used there. So even then, you're getting very little circulating throughout the body. And so I'm just not sure that it really has a big impact on malignant growth over time. Now, having said that, it still makes sense to me just logically that you don't want to make it easier for the cancer to get glutamine. So, long-term glutamine supplementation at high doses ongoingly in somebody who has active cancer is probably not really a well-thought-out therapy. But for short-term indications, like, for example, when people are getting taxane chemotherapy, Paclitaxel or docetaxel, there's a couple of clinical studies that very clearly show that high dose, 30 grams of glutamine for 4 days, starting the day of the chemotherapy infusion, will minimize the risk of nerve damage from that taxane significantly, both the severity and the frequency of that nerve damage. So do I have hesitations about doing that? Absolutely not. I think that even at that dose, I'm not going to fuel that tumor growth really to any significant level. Plus, I'm going to mitigate a major toxicity that could have implications for that person long term. And I think that's kind of important. Yeah. And I think a lot of the new studies that are coming out are really, they're looking at doing a couple things. Like there's one, I know they're looking at trying to block the pathway of glutamine utilization with a particular drug. So it doesn't really have anything to do with the sources of glutamine. It has to do with finding a drug that blocks that pathway. That's a really different thing than stopping glutamine. So, I think this is controversial, and I think it's unfortunately been sort of the effect of this biochemistry has been overgeneralized in a clinical context.
What about instances where the timing of giving a nutrient can have different effects? For instance, I think there's stuff on carnitine, is that right?
Mm-hmm. So carnitine is an interesting one, actually. There's lots of issues with carnitine. So first of all, it really works great for people getting platinum chemotherapies in terms of helping to minimize fatigue, also for radiation, really a nice synergist. And there's another chemotherapy that causes nerve damage, and fatigue, which is taxane. So there's some thought that maybe carnitine would help reduce nerve damage, because that's one of the things it does with the platinum chemotherapies. But in fact, when this was looked at, actually carnitine makes that neuropathy worse in people receiving the taxane drugs. So it's kind of considered a contraindication now for people on taxane chemotherapy. Also, the dose is really important. It seems like there is kind of a minimum of at least 2 grams, preferably 4 grams, to really see an effect. So I think sometimes, we talk about nutrients as if it doesn't matter what dose, but dose is really important.
Oh, absolutely.
In, its effect.
I recall talking to Janet Schloss, Dr. Janet Schloss, I should say now, PhD, who's worked a lot in cancer care. And I think she was talking about the timing of giving carnitine for CIPN in certain drugs, that you don't give it during the chemo, you give it afterwards. If you give it during the chemo, it worsens their CIPN.
I think what she's referring to is this study of the acetyl L-carnitine was actually used in this study, and it was a good study. It was a double-blind, placebo-controlled study, and these were women who were getting taxane chemotherapy, and when they were concurrently getting acetyl L-carnitine, they actually had much greater rates of nerve damage.
Right.
And so I'm not sure about the timing. I mean, generally speaking, it's given concurrently with chemotherapy, like with the oxaliplatin or cisplatin or carboplatin. You just sort of take it throughout the whole course of that chemotherapy, and there's a reduction in neuropathy.
Right,
typically.
Right. So you wait till after the full cycles of taxanes have been given, and then you would start ALC,
right.
ALCAR. Is that right?
Oh, I see. Yeah, so maybe that's the timing she was referring to. Yeah, so if you want to try using it to reduce the neuropathy for taxanes, which it may or may not, then you would definitely want to wait until the taxane is out of the system, not coming back in, and then try it.
I think one of the other things that came out of Janet Schloss's research was in those ladies on, I think it was Paclitaxel, that it may be worthwhile, certainly looking at their history and seeing if they're at risk of B12 deficiency, and potentially even testing for transhalocobalamin and B12 levels to make sure that they've got enough, because they were able to rescue somebody's CIPN to a certain degree, which was, like, to me, it's a groundbreaking thing, this. A simple vitamin that can rescue
that's
therapy.
Great.
Yeah. And therefore the lady can have the taxane, and therefore the lady can get the benefits of the chemotherapy.
Right, especially since maybe the other options are more limited. And another thing just to think about with carnitine, going back to that for a moment, is that I think it's important that we don't pigeonhole these nutrients into one effect. One of the reasons why acetyl L-carnitine in particular, or carnitine in general, is so much a part of my recommendations is because, yes, it helps to prevent neurotoxicity, but it also is very helpful in preventing cardiotoxicity, specifically with things like adriamycin, and even, I think, aromatase inhibitors and Herceptin. And it is also very good for fatigue, just general muscle fatigue, so really helpful for radiation. So you've got, anytime, there's a nutrient that has all those different effects, I think it's something we should really consider.
What about things, nutraceuticals like diindole methane? Do you have issues during any chemo with DIM?
I don't, and I'm just hesitating a moment because it's also something I don't go to a lot right up front with chemotherapy. So typically, that's working to modify estrogen metabolism towards its least carcinogenic metabolites, but it also has been shown to have a very specific immune effect, and it helps to reduce some of the immunosuppression around tumors and to stimulate tumor lymphocyte infiltration. So it has kind of a specific immune effect as well, and it works on.
So would you use it either side of chemo?
Yes, and it works on relieving fatty liver. And so those are all things that kind of are more important long-term, number one, and really after chemo is done.
Yeah.
So I tend to kind of put that on board after the course of chemo is complete.
Yeah. One thing that's come up with me recently is the use of melatonin, particularly in things like glioblastoma multiforme, and particularly in an age group commonly affected by that, and that is kids. Now, can I ask, how do you use melatonin, and what issues do you find with it, or what sort of, cautions do you have around its use?
So I use melatonin a lot because, quite frankly, it's one of the best evidence-based natural therapies in oncology from a natural perspective. Hundreds of clinical trials, and the results are just almost uniformly consistent in terms of reducing the side effect profile from chemotherapy and radiation by about 50% typically, and, improving overall survival anywhere from 30 to 50%. So clear benefit. That being said, there are some times where it doesn't seem to be the right thing for somebody. So there's a certain percentage, maybe 10% or so, of people who take melatonin that have a paradoxical reaction to it. So instead of getting sleepy, they get really wired. And you can't really give, you think, well, gosh, okay, then take it in the morning, but they just get sleepy in the morning. So it just doesn't really seem to work in those people. Sometimes you can kind of work them up to a good dose, but the dose in the clinical literature for the most part is 20 milligrams of melatonin. And so you're really looking at almost a pharmacological dose of melatonin. And there's been some really nice articles that differentiate the physiological effects of melatonin. So what happens when we have just our own endogenous levels versus the pharmacological effects. And they're a bit different. Like, for example, just a really quick example is a physiological level of melatonin tends to help cells pause in their cycle of division to do some repair.
Yep.
Whereas a pharmacological dose will help to kind of push the cell into apoptosis or suicide. So there's definitely a differential effect at that dose. So I tend to use it more often than not with kids. Generally speaking, I wouldn't use it as a sleep aid for a child that does not have cancer, because I think there's lots of other more safe things to use, because kids can have adverse reactions to melatonin. But for a child with a brain tumor, I would definitely use it, because there's reason to think it should be helpful, and there's a lot. They don't have much to lose by trying it, basically. So,
what about probiotics? Now, there has been some issues with Saccharomyces boulardii, haven't there?
Yeah, so probiotics are interesting too, aren't they? They're, of course, there's the issue of normal, healthy, so-called healthy or commensal bacteria in somebody who has an intact intestinal system, no extraneous devices in their vasculature. Not, there are healthy bacteria, and putting a bunch more in the gut is not going to be an issue. But for people who have chemotherapy, one of the almost universal side effects of chemotherapy is to increase hyperpermeability of the gut, or to cause GI leakiness. And with that leakiness, you're going to get some of these bacterial fragments into the blood, which even as a commensal bacteria are going to initiate immune response. Now, this is kind of interesting, because some people think that's actually part of how chemo works, is that the gut gets leaky, these bacteria come through, they stimulate immunity, and that immunity is then kind of heightened and is able to attack tumor cells more effectively.
Yeah.
And the flip side of that is, if somebody's really deficient in their white count, and so their white count is below normal, then there are reported cases of septicemia, even from commensal bacteria.
Yeah.
So I kind of use as a general rule of thumb, if somebody's white count is within normal range, then I'm fine using probiotics. But if they're below normal, then I hold it. And I don't think it's, wise.
What about the use of probiotics, like, for instance, I think especially Saccharomyces boulardii, when people have got a central line?
Yeah, so I think there's been some reports of some Fungus Amia from that Saccharomyces in people with ports. I don't really know why that is exactly, because where's it coming from? Like, the ports are just generally, you have to be so careful with ports, because they just can be these reservoirs of infection, and platelets get stuck to them, carry stuff around. They just have to be taken care of so carefully.
Yeah, so you're right. I mean, that's the reports that I've read were, the well-meaning nurse was apparently giving the Saccharomyces boulardii, theoretically got some of the product on her fingertips, then went to clean the central line, and ended up inadvertently causing a portal of entry, basically, for the organism, and therefore fungemia. I think the patients that I've read were all rescued with amphotericin, but notwithstanding, that's a very serious thing, and you should be avoiding it, and you should be absolutely fastidious with central lines. But I think the big thing is, unless you are that, you've got to be really, really careful with SB.
Yeah, and I think that point is so important. I've actually had I had a patient who was getting some intravenous vitamin C therapy during their chemotherapy and was going to another practitioner to get the IV vitamin C, and the other practitioner was flushing the port, but the hygienics around the office wasn't good enough and had actually introduced an infection.
Yeah.
So people have to just guard their ports like a rabid dog.
Absolutely.
Basically make sure that they're being flushed appropriately, everything's super hygienic. Yeah, really clean.
Yep, better than everything. Lise, any other sort of general hints and tips? I guess one of the closing things for me is when you're looking at or when you're avoiding certain supplements because there is a real issue. For instance, like you can't use St. John's wort because that is a well-known, well-documented issue. What sort of things can you use if somebody's suffering from anxiety, which of course is a big ongoing issue for people journeying through their cancer and even thriving afterwards? They have this ongoing, anxiety about what's going to happen now. So where do you sit? What do you tend to use?
Well, so for example, in that situation, I would think about lavender extract, which has been shown to not have clinically significant interactions in human studies and is a very reliable anxiolytic. For depression, I think going the amino acid route can be quite helpful. So either assessing for amino acid deficiencies and repleting those, or looking at, simple things like magnesium or B6 deficiency can be very helpful as well. Amino acids are a little tricky too. There's, for example, SAMe, which we know is a great antidepressant. Really quite miraculous for some people, is also a source of methionine, which is an angiogenic factor. And there are even some trials which are looking at, can we restrict methionine from the diet and use that as a means to control tumor growth?
Yeah.
So that would maybe be something not to use, unfortunately, in somebody who has active tumors. But somebody who has no evidence of disease, I'm fine with using it.
Yeah.
So I think we just have to be thoughtful and, really think about anything that we're using. Okay, so is there any data on this sort of feeding or spurring cancer growth? Is this data human data? Is it just, cell-based data? Is it theoretical? And then, how long am I going to have somebody on this? Are there any other alternatives? And just kind of really go through almost a mental checklist with every item to try to be as safe as we can.
Yeah. And I guess the last point for me to make is, because there is more and more research coming up about concurrent nutrients with chemo and radiotherapy, I think what we need from you, Lise, is a new edition of the Definitive Guide to Cancer. Because I've got to say, I found particularly that middle section of the book, I found that so especially useful to just look up as a reference to go, that's it, that's what I need to do, bang. And thank you for taking us through the real issues of the dangers of supplementation today in FX medicine.
Yeah, well, thank you very much, and I'll work on that edition. It's a little overwhelming because there's so many new drugs approved, like almost on a daily basis.
Yeah.
I don't even know how I would maintain my sanity. So if you're willing to have crazy, no longer sane, no longer with us, Lise, then maybe I'll do it.
This is FX Medicine. I'm Andrew Whitfield Cook. This podcast was brought to you by Bioceuticals, the Dr. Lise Alschuler Seminar Series.